Okay, so here I am with yet another one of my presentations. I was going to put my face down in the lower corner of this, but then I thought, nah, they don't want to see me. They probably don't really want to hear from me. All right, so anyways, here we go. Pharmacology. And this is from Rad 211. So this is just, and this isn't the whole PowerPoint. I'm not going to make you sit through the whole thing. This is just a review of some drugs. Okay, so we're going to take a look at some medications and how we administer them. Okay, so right off the bat, what we're going to do is look at the routes. Oral. Okay, we can give a lot of medications are in oral form of some sort, like a liquid medication, cough syrups, things like that. And then we also pass out a lot of pills at the hospital. So a lot of our medications are in pill form. Sublingual, stuff like nitroglycerin and Zofran. These are things that can dissolve in the patient's mouth, and they don't necessarily need to be swallowed. They can just be absorbed through the mucous membranes, which is really, really handy if you have a patient that's being violently ill. Like if they're throwing up everything, then if you give them like Zofran in sublingual form, that stuff dissolves in the mouth, and that way even if they're throwing up, they still get the medication. Transdermal, things like nicotine patches and fentanyl patches, these go on the skin. Stuff like hydrocortisone that can be rubbed into the skin. We also have topical antibiotics, like for example, bacitracin. That's a good one. And then things like asthma inhalers or breathing treatments. You know, those albuterol breathing treatments that we give patients in the emergency department. That's inhaled medications. And there's also such thing as inhaled contrast agents, but those are, we don't use those in radiology anymore. Those used to be used back in the day in order to be able to map out the bronchial tree, but then in nuclear medicine, I think occasionally they still do VQ scans in nuclear medicine, and that requires an inhaled radionuclide. Okay, so parenteral. Parenteral just means any way besides through the GI tract. So this is stuff that doesn't require like either a suppository or for the patient to swallow anything. And intravenous, you know, of course, that means into the patient's veins. Intradermal, that's an injection into the dermal tissue, you know, below the subcutaneous layer. Intrathecal, don't forget this one. Intrathecal is one that the registry likes to ask about because this is what we do in myelography. The thecal sac is the membrane that surrounds the spinal canal, and if you're intrathecal, that means you're injecting into the subarachnoid space. And intramuscular, like a lot of vaccinations that we give, like tetanus vaccine, stuff like that, that's delivered intramuscular. And then subcutaneous, whenever you guys did your TB skin test, you got a subcutaneous injection then. And that is just barely under the skin, and it causes like a little bubble. Now, for the purposes of our work, most of the time we're going to be injecting things into patients' veins. You won't be required to administer a lot of injections unless, one minor caveat, if you go to work for an outfit like Medac, for example, where you're hired as an X-ray tech, but you're also almost like an LPN because you bandage wounds and you also give injections to a limited extent. You do a lot of stuff in addition to just shooting X-rays. So at a smaller hospital or a doctor's office, you may wind up having to do blood draws, all kinds of stuff. The X-ray tech that works at my doctor's office, for example, whenever I go in, not only does she do my chest X-ray, she also does my EKG, and she also draws my blood, you know, for my annual blood work. A little bit more about drugs. Local anesthetics. We use these a lot. Lidocaine is, that's a medication that numbs the skin, like in a small area, just right around the injection site. But if it gets injected into the patient's bloodstream, it can cause cardiac issues. Now, in some cases, cardiac effects are good. As a matter of fact, sometimes if a patient has Like if they're in some kind of an arrhythmia, the doctor will inject lidocaine, and that will actually help the patient's heart rate. Marcaine and Sensorcaine are just different trade names. They're basically the same thing. And these are used a lot of times in arthrography. Like if the doctor's going to inject into the patient's joint space, like for a shoulder arthrogram, a lot of times they'll mix the contrast agent with Marcaine or Sensorcaine, and that it helps the patient be able to tolerate the injection a lot better. And so the doctor will inject this directly into the site where they're working. Don't forget the 6 rights. You'll probably see this again. The right patient, always make sure that your patient identification is correct, that you've got the right drug, the dosage is correct, the time of drug delivery is correct, the route. There are some medications that are totally fine for the patient to swallow, but if they're injected into the bloodstream, they can cause a huge issue. One that comes to mind right off the bat is gastrografin. You don't want to inject that into the patient's bloodstream. It can give them a heart attack. And don't forget your documentation. Anytime that we're going to give medication to a patient, all this stuff has to be documented, as well as part of your documentation is how well the patient tolerated that drug. Did they have a reaction or did they not? Okay, solutions. Osmolarity. Osmolality sound similar, but they're not the same thing. Osmolarity is the quantity of solute, the stuff that we're dissolving, per kilogram of solution. And our solution is typically like whatever that material is and water. Osmolality is slightly different. This refers to the quantity of solute material per kilogram of water. And osmolality is what all of our, like if you look at a OptiRay 320, for example, and you look at that and it says, okay, there's 320 milligrams of iodine per deciliter of water. And so the osmolality is what's referred to on the label of the medication. So whenever we're talking about contrast agents, we're generally talking about osmolality as opposed to osmolarity. So if you know the difference between those, then nobody can trick you on a test question. More about solutions. Most of what we inject into the patients is isotonic. In other words, the osmolality of our solution is approximately the same as the patient's blood. This is why, we don't inject just plain old tap water into a patient. That would be a hypotonic solution. And that could cause some issues with the patient's electrolyte balance, for example. So most of the time we want an isotonic solution. In other words, we want to inject something into the patient that's going to be very compatible with their own chemical balance. A hypertonic solution would be strong. That would have like a lot of solute as opposed to an isotonic solution. Now, a lot of our contrast agents, like OptiRay 350 and Omnipaque, like the high iodine concentrates, some of those do tend to be hypertonic, but we don't administer very much of it. So like an OptiRay dose would be like 100 milliliters, which if you think about, what is 100 milliliters compared to the whole volume of the patient's blood, which is like 5 liters, it's not all that much. So generally it doesn't cause the patient to have any problem. But just remember these: isotonic, hypertonic, and hypotonic, and what they mean. Now, sometimes our patients need to be sedated. If we're going to be sticking a tube down somebody's lungs, then if we don't give them some kind of sedation, they're probably going to start fighting. Even if they're tied down, they're still going to be fighting. So we need to relax the patients. So a lot of times the doctors will give them things like anywhere from Valium, like a lot of our MRI patients get Valium, just to kind of help them relax. But then we can also get a little more aggressive. We can use things like Ativan and Versed, to basically make the patient loopy. We don't want them to be completely knocked out, but we want them to be almost in a state where they're semi-conscious. They're kind of in and out of sleep. Now, when a patient is in that kind of a situation, they have to be monitored constantly, and you can imagine why. If we give this guy just a little bit too much medication, we might make him stop breathing, and that wouldn't be good. So patients have to be monitored constantly. Here's some common drugs that you'll see used in most departments. Morphine is an oldie but goodie. It works. It's a very good painkiller. Fentanyl is a very, very strong painkiller. It only takes a few grains of fentanyl to kill somebody, so this has to be administered very carefully. And always, with a doctor will be standing right there when fentanyl's being administered. Valium, that's something that a lot of times patients can just take before they come to the hospital, provided they have a driver. So the doctor sometimes will say, look, the patient's coming in for an MRI and they're anxious about it, so we're going to give them some Valium in advance. So by the time they get to the hospital, they're feeling nice and relaxed. Ativan is a anxiolytic. It helps reduce anxiety, relaxes muscles, can make patients, like really slur their speech. But we had, like one night I was riding on the ambulance and we picked up this lady and she had a couple cuts, she was bleeding. We had her patched up, but she was really kind of freaking out. And the paramedic that I was riding with, she was like, okay, we're just going to give you a little something here. Gave her a little shot of Ativan, and boy, it changed that patient's attitude. She became really pleasant and easy to deal with after that. So Ativan, that's good stuff, magic medicine. Phenergan is another kind of a magic medicine. If a patient is being very nauseous, then this will stop them from throwing up. Now, it does also have the side effect of making them sleepy. Now, I don't know if you guys have ever been in the ED whenever the doctor gave somebody morphine. I've had patients before that the doctor would give them morphine and then I'd take them back to the x-ray department and then they would start vomiting, like really hard, projectile vomiting even. Morphine has that effect on some people. So a lot of times, in order to head that off, the doctor will give the patient an injection of Phenergan and then give them the morphine. And that way the Phenergan kind of counters the nausea reaction that the patient has. Now, here's some medications that we keep on hand in case of emergency. Benadryl, which is aka diphenhydramine, that's a good all-purpose antihistamine. It helps put down any kind of allergic reactions that a patient has. And as a matter of fact, you can have Benadryl at your house. If you get a bee sting or something, take 2 or 3 Benadryl, and that will definitely help mitigate some of the effects of the bee sting. Epinephrine is a vasoconstrictor, but it's also a bronchodilator. Epinephrine is something that the body produces called adrenaline, and epinephrine is just like a, like a synthetic adrenaline shot, and it tightens up the blood vessels, so it helps raise blood pressure, and it also opens up the bronchial passages so that the patient can breathe. And if a patient's having like laryngeal edema, epinephrine can save their life, absolutely. Atropine is a medication that it raises the heart rate, so it's kind of like a stimulant, but it also has the effect of drying up mucous membranes. So like if a patient's going to have a bronchoscopy, sometimes they'll give them atropine beforehand to, so that their lungs aren't so juicy whenever the doctor's trying to maneuver a bronchoscope down through there. And then Narcan is another magic medicine. If a patient's having like an overdose, if a patient's taking too much heroin and their breathing is way depressed, then Narcan can save their life. Narcan blocks the effect of opiates, and it will restore the patient's breathing. Their autonomous nervous system can kick back in, and yeah, that's life-saving stuff. Some pre-treatments. Now, sometimes patients come to us and they have a known drug allergy or suspected drug allergy, and in this case, the doctor might prescribe them Benadryl and prednisone beforehand. So like for a day in advance of their procedure, they start on prednisone and Benadryl. And so since they're pre-medicated, if they do have an allergic reaction, then this will help mitigate that so that it's not so bad. Okay, some contrast agents. Most of the contrast that we use is going to be positive contrast, but any contrast media is a substance introduced to either increase or decrease the density of the structures and enhance the contrast on the radiograph. Now, contrast media like iodine or even barium sulfate are considered pharmaceuticals. They cannot be administered without a doctor's order. And the reason why we need contrast media is if you think of, for example, the urinary system, which is the subject of this particular unit that we're on, if you take an x-ray of a patient's abdomen, you might kind of be able to see the kidney outlines a little bit, but you are almost certainly not going to be able to see the ureters. Those things are not going to be visible on just a plain old abdomen x-ray, unless we have filled them full of a contrast agent, in which case they're going to show up very clearly. We'll be able to see them quite easily once we've got some contrast on board. And that's the whole reason why we use contrast, is to enhance the tissue densities between adjacent structures. Okay, now all of the procedures that we refer to as special procedures require the use of some form of contrast agent. We're trying to look at soft tissue structures here, like blood vessels or intestines or the renal pelvis, you know, that kind of stuff. And so we almost always are using positive contrast agents. The only time we use air or gas is when we're doing golly Pete, what am I trying to say? Double contrast barium enema and double contrast upper GI when we're looking at the patient's stomach. We'll give them gas crystals, or the doctor will just simply pump some air into the patient in order to help enhance the contrast of their stomach or colon, whatever we happen to be looking at. Now, some considerations for contrast media. Miscibility. That just means, okay, how well is this going to mix with the patient's own bodily fluids? So water mixes really well with blood. Oil does not. If you were to inject some Wesson oil into a patient's bloodstream, then you're going to cause an oil embolus, and that's going to wind up being bad news for that patient. So miscibility is very important. Viscosity refers to how thick a contrast agent is, and technically viscosity just means resistance to flow. So you can imagine if you take like a jar of honey and tip it upside down, then that honey might not really go anywhere. It's a highly viscous material. Whereas if you take a jug of water and turn it upside down, what happens? Well, unless the lid is on there securely, it's all just going to pour right out. That's viscosity. And remember, viscosity is inversely proportional to the temperature. So as the temperature goes up, viscosity goes down, and vice versa. If you can imagine taking like a glass of water and putting it into the freezer for a while until it turns solid, and then you turn it upside down, nothing happens. Well, okay, it's solid. That's like the ultimate viscosity. It's not going anywhere. Now, something else we have to worry about is potential toxicity. Every contrast agent we use, except for barium, is mildly toxic to the patient, and so, giving them too much could wind up being very harmful. Persistence refers to how long this agent stays in the patient's system. So, any kind of material that has a very high concentration of iodine is going to have a higher persistence. In other words, it's going to stick around longer, and we're going to be able to use it. Oil contrast agents have a very high persistence. So does barium sulfate. Barium sulfate, until it gets eliminated by the patient's body, we can see it. So if it was to get loose into the peritoneal cavity, for example, it would just be there until further notice. I don't know how we'd get it out of there. Osmolality, we talked about already. That just refers to the density of a solution. How many molecules of iodine are in a deciliter of water, and we want that osmolality to be close to what the patient's own fluids are. Now, here's some different kinds of radiopaque contrast media. We have water-soluble liquids like Gastroview and Gastrographin, Omnipaque, Opdirate, Isoview, Visopaque. Those are all water-soluble liquids. We also have some pills. Sometimes a doctor might want a patient to swallow like a barium pill, and we use a lot of suspensions of barium sulfate. We use thick and thin barium. Like for CT studies, we can use barium, but it has to be very, very thin for those studies. But for studies of like the upper GI, sometimes we use a combination of thick and thin barium. And then we have oil-based contrast agents, and those have to be used very carefully by a radiologist that knows what he's doing, because they can be dangerous. And ionic contrast agents. Ionic contrast agents are cheap. They consist of iodine salts dissolved in water. Now, the thing is, these salts, when they get injected into the patient's bloodstream, they tend to break up into positive and negative ions. The cations are negative, the anions are positive. Get it? Like cathode and anode. Now, the good thing about the ionic agents, in addition to them being cheap, is they have a high concentration of iodine, and they are very easy to spot on an X-ray. So they show up really, really well. Unfortunately, they do happen to be somewhat toxic, and if they get into the patient's bloodstream, they can actually throw off their electrolyte balance and cause them to have heart failure. So be very, very careful when using ionic contrast. And here's a little bit more about ionic contrast agents. These are a benzene acid ring, and here's some examples. Hypaque, renographin, Conray, cystoconray, which is used to image the bladder, and it works really well for that, and Gastroview and gastrographin. So you've probably seen a lot of these in the hospital. You've probably used them, given them to your patients. And as long as the patient's just drinking this stuff, or if we're putting it into their lower intestine, like for a single contrast enema, then typically the patients don't have any problem with them. Here's a few more. Hexabricks. We used to use hexabricks all the time for, oh golly, for HSGs. That was kind of like the go-to contrast agent. It's an ionic agent, but it's specially buffered so that it doesn't tend to hurt a lady when it gets injected into her uterus. Nowadays, I think they use non-ionic contrast almost exclusively for HSGs, because even though Hexabricks was buffered, it still wasn't without risk. And they're trying to go, low risk as much as possible. Now, non-ionic contrast agents. This is what we use most of the time at the hospital. These have a lower osmolality. They don't have as high of a concentration of iodine, but the good thing is they don't break up in the patient's bloodstream nor in their stomach, and so they're basically non-reactive in the patient's body. So we can inject these into the patient's bloodstream or even into the patient's spinal canal, and we don't really run that much of a risk of damaging the patient. Now, the risk is never going to be zero. But with non-ionic contrast agents, the risk is really low, and so these are very much preferred. They do cost a little more, but nowadays there are so many companies making these things that the cost has gone down a lot. They're not near as expensive as they used to be. Now, oil-based contrast agents. We used to use these for HSGs, silograms, and occasionally for bronchograms. They used to be used for myelography, believe it or not, although the complications were off the chain. People would have reactions. The oil contrast would get in the spinal canal and still be there like 10 years later, so it wasn't ideal. Here's some examples. Thiodol, which is still occasionally used, lipiodol, dionysil, and Pantopaque. Pantopaque turned out to be really toxic stuff, so that got discontinued years ago. And anytime you're using an oil-based agent, you don't need very much of it because it shows up really well on an X-ray, and it also doesn't tend to break down very fast in the patient's body, so it is a long persistence agent. Okay, so oil-based, you may still see used from time to time, but like I said, it's very specialized, and only certain radiologists would ever mess with it. Negative contrast agents, once upon a time, they used to inject CO2 into patients' spinal canals and do what's called milligrams and pneumoencephalograms. Crazy stuff, but you know, it was what they had at the time, and it kind of sort of worked. Some negative contrast agents you may see used. Air, we use that all the time. Oxygen, used very sparingly. Carbon dioxide is very popular, especially for, we use carbon dioxide a lot for laparoscopic surgeries, more so than we do for a contrast agent. And nitrous oxide is another possibility. Air and CO2, I'm sorry, air and oxygen tend to be the most dangerous. And the reason for that is because your body is specifically designed to hoard oxygen. So if oxygen gets injected, the body doesn't give it up all that easily. It kind of sticks around. CO2 is exactly the opposite. Your body is designed to get rid of carbon dioxide. And so if you put carbon dioxide into a patient, then their body will begin to try to expel it almost immediately. Okay, choosing a contrast agent, it's up to the doctor. Okay, we don't really get to choose any of this, but the doctor would have to choose based on persistence of the agent, how long do we want it to stick around, the viscosity, you know, how easy it is to push. If a doctor's having to push contrast through a very long catheter, then they need low viscosity contrast, else, you know, it'd be very, very difficult to push. Iodine concentration is important because the more iodine there is, the easier it is to see the contrast agent. And if you're doing a study like aortography, where the contrast is getting flushed away almost as fast as you can push it, then the iodine concentration has to be high or else you really can't see anything. Patient physiology. Some patients cannot tolerate like a really strong contrast agent. So if a patient has kidney trouble or something like that, then we might use like a weak Vasovagal or something that has less contrast in it. It's not as easy to see, but it's safer for the patient. And don't forget about your BUN, B-U-N, and creatinine numbers. We always, before we're going to give a patient a contrast agent, we have to check BUN and creatinine. And why are they so important? Well, I'll tell you. The blood urea nitrogen. This is a way to tell how well the patient's kidneys are functioning. Basically, the BUN, the blood urea nitrogen, a lot of that is coming from your liver, and then it gets created in the liver, but it gets eliminated by the kidneys. So if you're looking at the BUN and the BUN level is high, in other words, there's too much of it in the blood, that means that the kidneys are not removing it correctly. So there may be an issue with the patient's kidneys. Another material is creatinine. Creatinine is a waste product that comes from just breaking down food for energy. And creatinine levels, like if you're eating or sleeping or exercising or whatever, creatinine tends to be produced at a relatively steady rate. So it doesn't matter if the patient's eaten that morning or not eaten. We can take a blood measurement and see what their creatinine level is. And if that creatinine level is high, then that means that their kidneys have got some kind of an issue. We don't necessarily know what that is, but we know something's wrong. Kidneys are not functioning normally. Now, any substance that goes into the body must be removed somehow. Now, IV contrast agents tend to be removed via the kidneys. So if we're looking at a patient's blood work, then their BUN level, and remember, we're looking at the blood, not the urine. The BUN level needs to be less than 30 milligrams per deciliter, and the creatinine level should always be between 0.5 and 1.5 milligrams per deciliter. Now, if the creatinine level is somewhat outside those ranges, it may still be okay. That would be up to the radiologist, and the radiologist would have to know the patient's history before he or she can make that call. But, you know, for general purposes, 0.5 and 1.5, you know, if your patient's creatinine level is in between there, you're probably fine. A little bit more of excretion. Bilopaque. This is an iodine compound that can be used for gallbladder studies. So Bilopaque is not very much used anymore, but once upon a time it was. And it was used to inject into the patient's bloodstream, and then the liver would pick that up and deposit it into the gallbladder, and then we could take images of the gallbladder. And it got filtered out of the system by the liver instead of the kidneys, but it was specifically formulated for that. Now, they still use something like this over in nuclear medicine for HIDA scans. So whenever you're over there doing a rotation through nuclear medicine, you may see them give an injection into a patient, and it's a radionuclide that's tagged with something like Bilopaque, so that it concentrates in the liver. Now, some patients will have a reaction to a contrast agent. And if there's going to be a problem, you'll typically know it real quick. 70% of allergic reactions to contrast agent occur within the first 5 minutes of the injection, and then the remainder tend to occur within 15 minutes. So you're going to be with the patient for at least that long, I would imagine. So if there's going to be a reaction, you're going to be around to see it. Now, luckily, the contrast agents we use today tend to not react with the human body, so reactions are extremely rare. But there are some things that can happen. Now, we can accidentally overdose the patient by giving them too much of a contrast agent. Now, some patients will have a psychological reaction. In other words, they kind of freak themselves out. They're very, very anxious. And sometimes they're so anxious that they can actually cause their own cardiovascular reaction, which is vasovagal. What happens is they get themselves so worked up that their blood pressure drops and they pass out. They may pass out and vomit. It's not necessarily life-threatening unless the patient was to start choking or something like that. Now, system triggering reaction is pretty normal, actually. A lot of times when a patient gets an injection of a contrast agent, they'll have like a warm, flushing feeling. They may have a mild sense of nausea. They don't actually throw up. I mean, they may throw up a little bit, but usually they'll say, oh, I'm kind of sick in my stomach. But then that passes. But if a patient has an anaphylactic reaction, then that can be certainly life-threatening. And we're going to take a look at some different reactions here. Now, here's some stuff that's normal. A warm flush sensation over the body, a metallic taste, a spicy taste in the mouth, little mild nausea, some tingling in the fingers and toes. That's pretty common. And then there can also be some pain at the injection site because this contrast agent can be irritating to the inside lining of the veins. And here's some different reaction classifications. A mild reaction would be nausea, vomiting, limited breakout of hives, coughing, itching, sneezing. Okay, that's a mild reaction. It may require some attention on your part, but it's certainly not life-threatening. Moderate reactions are an outbreak of urticaria, which is like a widespread rash on the body, edema, which is swelling, tachycardia is an accelerated heart rate, excessive vomiting. If a patient starts vomiting and they can't seem to quit, then that can indicate a moderate reaction. They can turn really red, erythema, and then their nose can start running, like pouring thin mucus. And here's a picture of somebody with urticaria. It's just a widespread outbreak of hives. Now, here's a list of some severe reactions. Severe hypotension, cardiac arrest, respiratory arrest, pulmonary edema, that's fluid buildup in the lungs. Myocardial infarction would be a heart failure, arrhythmias, convulsions, laryngeal edema, which can keep a patient from being able to breathe. They can suffocate to death. Laryngospasm, again, that can cause them to not be able to breathe. They can suffocate. If they turn blue, then that's cyanosis. Dyspnea is a severe difficulty breathing. They can go into shock if their blood pressure drops too much. Paresthesias, which is that's like a sensation in the extremities. And renal failure. That's, kidney function stops. Okay, this is all considered severe reactions, and you're probably looking at this list going, oh my gosh, yeah, this is all code blue type stuff. Now, vasovagal reaction is the most popular thing we see, and this is a reaction, it basically is based in fear. The patient's coming in for an examination, they don't really know what's going on, they're scared, and so they might actually pass out as you're approaching them with the needle before you've ever even touched them. It's a fear reaction, and it's can be characterized by dizziness, weakness, bradycardia, slow heart rate, decreased blood pressure. So be on the lookout for this. Now, vasovagal reactions can be mitigated hugely by simply communicating with the patient. Just tell them in advance what to expect, and that way when it happens, they're like, oh, okay, the guy told me this was going to happen, and that kind of helps put them at ease. We ask questions to the patient, allergies. Do you have any known allergies? Do you have asthma, hay fever, drug allergies, allergy to iodine? A lot of people don't have any clue, and some people have allergies to food. And the reason why we ask these questions is because patients that are allergic to one or two things, they have a higher chance of being allergic to something else, including our medications. So these allergy questions are important for the doctor to know before he orders us to inject the contrast. Okay, now, whenever you're drawing up medication, read the label. When you're at the cabinet, before you draw up, and again before injecting. The doctor's really counting on us to make sure that we, don't make any mistake. And typically, like if you're with a doctor on a myelogram or arthrogram, you're going to show them the label, and then they're actually going to draw up and inject. But if you're by yourself in the CT department, it's going to be all you. You're going to be doing everything. You're going to consent the patient, and you're going to draw up, and you're going to inject. And if there's any mistakes, it's going to be all you. Because there's sometimes you might be at a site where there's not even a doctor in the house, or maybe there is a doctor down in the emergency department, but not necessarily watching right over what you're doing. So be very careful is what I'm saying. Here's some other complications that might crop up. It's possible for a patient to have drug interactions based on other medications that they're taking that they might have forgotten to tell you about. We can also damage the vein that we're going into. We can extravasate, which means that basically we've got our needle mispositioned, and instead of being in the vein like we thought it was, it's actually in the surrounding tissue. And then when we go to inject, instead of the contrast going into the patient's veins, it goes into their muscle or subcutaneous or something like that, and that can be a big mess. Some patients will bleed excessively even if they're not on blood thinners. It's like you pull the needle out and they just keep on bleeding. So be sure you know where all your equipment is. Definitely know the location of the crash cart, and hopefully you know the number to call for a code blue. All right, so that basically is everything I had to say about medications and contrast agents. So yeah, we're getting on to the 40-minute mark here, so this is a little longer than I'd planned on. But hopefully this has been a good review for you, and next week I'm going to have some questions for you on patient care and medications. All right, take care. I'll talk to you later. Bye.